All right. So today's class, we will be discussing the musculoskeletal system, specifically health, disorder, and treatment. I'm just going to briefly mention health in regards to the musculoskeletal system, because we do cover that in other courses as well. So the main goals for today are to discuss the anatomy and function of the musculoskeletal system, disorders as they relate to our clients and the developmentally disabled community, and treatments and interventions for these disorders. So the first part of the musculoskeletal system that I want to discuss are bones, which is pretty basic. The primary function of bone is to provide structural support to the body, as well as protect the internal organs, produce red blood cells, and store minerals for future use. The muscles have multiple purposes. There are three types of muscle, but for the purpose of this course, I will only be discussing two of them, or skeletal muscle. This is the muscle that attaches to our bones and allows us to move around. This movement is voluntary, meaning that we control when the muscles move. In some instances, such as cerebral palsy, it's not always the case, as neurological injury causes involuntary muscle spasms, as well as impairs the ability to move muscle with intention. Joints are the next part of the system. They are necessary in order for the muscle to move bone, facilitating movement. They also provide stability, allowing the body to adapt to external pressures in order to maintain posture and balance. Joints are also important for proprioception, which is the body's ability to sense its position in relation to the environment. Even with our eyes closed, we know relatively where our body is in space. And the next part that I want to discuss are the connective tissues. Those are made up of tendons, ligaments, and cartilage. Tendons are the tissues that attach muscle to the bone. If it were not for tendons attaching muscle to the bone, we wouldn't be able to move. This tissue also acts as a shock absorber, reducing risk of injury to muscle during activities such as running or jumping. And since they absorb that energy, they can also release it in the form of elastic energy. And that makes it easier to move. Again, think about jumping. You can kind of think about it like a slingshot. If you put pressure on that slingshot, pulling it back, and you let it go, you can actually, like, there's that increased force. So you kind of think about it that way. Next to ligaments, these are the tissues that support joints, connecting bone to bone. Think about the major joints like the knee, shoulders, and hips. There are multiple ligaments at each joint providing that structure. Ligaments also reduce the risk of overextension of the joint, preventing injury. And then cartilage is a tissue that provides support and flexibility. There are three types of cartilage: hyaline, elastic, and fibrocartilage. Elastic collagen is really just like in the nose and in the ears, so it doesn't really factor into our discussion of the musculoskeletal system, but it does exist. Hyaline cartilage is found in joints, the trachea, and nose, and it provides a smooth sliding surface. When this tissue breaks down, bone will rub against bone, resulting in grinding and pain. And then there is fibrocartilage. It is found in joints like the knee and between the vertebrae. It absorbs impact as well as provides support to the joint while decreasing friction between bones. So next we'll talk about musculoskeletal disorders in the DD population. And probably not very surprisingly, there is an increased incidence of these disorders in our clients as opposed to the general population. The disorders, even though there are many of them, I will be focusing on only these six: scoliosis, hypermobility, sprains and strains, contractures, osteoporosis, and arthritis, as these are disorders that you are more likely to see within your facilities. So starting with scoliosis, this is the abnormal side-to-side curvature of the spine. Your spine naturally has a slight forward and backward curve to it. With scoliosis, your spine curves left and right into either a C or S shape. Most cases of scoliosis are mild and don't cause symptoms or don't require treatment. Severe cases can cause uneven posture and pain and often require treatment. The side-to-side curve of the spine seen in scoliosis is categorized based upon its location in the spine, either in the thoracic or lumbar spine, or it could be in a combination of the both, also called thoracolumbar. There are four types of scoliosis. The first is idiopathic, and this accounts for approximately 80% of cases of scoliosis. And what idiopathic means is we actually don't know what causes it. It just is a part of growing. It's more common in individuals between the ages of 10 and 18 years because that's the period of time when bodies undergo drastic growth, drastic changes in development. And if there is a slight curvature to the spine already, that accelerated growth will actually exacerbate that curvature. Research does indicate, though, that it tends to run in families, like indicating that there is a genetic link. And like I said, it's generally diagnosed between the ages of 10 and 18 years, and it's actually more common in females than it is in males. Congenital scoliosis is a rare spine abnormality that a healthcare provider may detect at birth. It occurs when the vertebrae, the bones that make up your spine, don't form as they should during embryonic development. As you can see in the image B here, there's a vertebral malformation in this individual causing the spine to bend at approximately a 90-degree angle. Not all malformations are this severe, but this does illustrate fairly significantly what a congenital deformity leading to scoliosis would look like. The next type is neuromuscular scoliosis, and this is what you would see typically in our clients with cerebral palsy. This is a result of abnormalities in the muscles and nerves that support your spine that cause that curvature. It usually happens alongside neurological or muscular conditions like an injury, cerebral palsy, spina bifida, or muscular dystrophy. And then lastly, we have degenerative scoliosis. It is often a result of the aging process or a disease process in which muscles, ligaments, and the spinal column weaken over time, causing the spine to shift laterally or side to side. On to associated conditions. Individuals with Down syndrome are more likely to develop scoliosis than individuals without Down syndrome. Um, Approximately 7 to 9% of individuals diagnosed with Down syndrome will develop scoliosis within their lifetime, as opposed to the general population, which has a incidence rate of 1.5 to 3%. This is generally related to musculoskeletal issues like ligament laxity, which is basically loose ligaments, joint hypermobility, which I will discuss a little later, and hypotonia, which is reduced muscle tone. And all of those are associated with Down syndrome. A significant number of individuals who are diagnosed with Down syndrome at birth have also cardiac issues as well, sometimes requiring surgery. And what happens at that point is since they're having to cut into the muscle between the ribs to access the heart, when that tissue heals, it's forming scar tissue as well, which changes the way that the muscle grows. So the muscle actually becomes more stiff, kind of contracting and pulling in that area. And as the body grows, it can force the spine into that S or C curve. This type of scoliosis is called thorogenic, and that is a direct result of surgical interventions such as like or cardiac repairs. Next, I wanted to talk about cerebral palsy. Children who have cerebral palsy have a much higher incidence of developing moderate to severe neuromuscular scoliosis than the general population due to muscle weakness and associated balance and posture issues. Since neuromuscular scoliosis tends to be progressive, as the client ages, they may develop new onset or worsening symptoms of chronic pain, respiratory difficulty, balance and mobility issues, and in extreme cases, cardiac involvement. And the reason why this can lead to cardiac problems is that the shift in the spine alters the shape and space available in the rib cage for the heart. This impacts the heart's ability to pump effectively. The chronic stress on the heart can eventually lead to dysfunction of the heart's ability to passively fill with blood, um, which decreases the amount of blood that the heart can push out when it contracts. This can lead to a condition called congestive heart failure, which is characterized by difficulty breathing as well as swelling in the peripheral extremities, such as like the lower legs is where you'll see it more commonly. And it's what we call edema, which could be pitting or not pitting, and that could result in cellulitis, which is an infection of the skin, or leaping of fluids through the skin. The next associated condition that I'd wanted to discuss is Prader-Willi syndrome. It is strongly associated with scoliosis. Childhood risk is almost 70 or more percent until the skeleton matures. And this condition can range, of course, from mild to severe, but it tends to be more severe in individuals with obesity or specific subsets of Prader-Willi syndrome. Early detection of scoliosis in these individuals is important, especially as they may begin developing this condition prior to even the age of 4. Next is the Chiari malformation type 1. This is a structural defect in which the brain tissue extends into the spinal canal. This is often due to a misshapen skull or a smaller than average skull. 20% of individuals with this Chiari malformation will develop scoliosis as a result. This rate increases up to 60% in individuals who have a co-occurring syringomyelia. Sorry, I know that's a terrible word to pronounce, but that basically means a fluid-filled cyst that also sits in the spinal cord. The reason that they think that this causes scoliosis is because of an alteration of the cerebral spinal fluid impacting the function of the spinal cord. Because it disrupts normal development, this can lead to physical changes such as that lateral movement side to side of the spinal cord or the spinal column. Chiari malformation type 1 also affects the symmetrical length of muscles supporting the spine, and this actually will lead to pulling on one side of the spine versus the other, resulting in that curvature. And then last, I wanted to talk about Noonan syndrome. It occurs in 1 out of approximately every 1,000 to 2,500 births. This is a genetic disorder commonly resulting in short stature, heart defects, coagulation disorders, skeletal deformities, and developmental delays, as well as facial features, including widely eyes with drooping lids, low-set ears, and a webbed neck. Although this is a relatively common disorder, every person presents differently, some more severe than others. And diagnosis of this syndrome is usually a result of physical examination, genetic testing, and due to the risk of cardiac involvement from this condition, the heart as well as other internal organs would need to be examined accordingly. So on to treatment and considerations. Scoliosis screenings in elementary and secondary school are common to seek out cases and start prompt treatment for idiopathic scoliosis, as that is the most common, and that's generally the age when you would start to develop. Early intervention significantly increases the probability of positive treatment outcomes. As mentioned before, this condition is most frequently diagnosed after the age of 10 and is more common in females than males. Women or girls are 10 times more likely to develop idiopathic scoliosis than males, which is pretty significant. The severity of scoliosis may worsen over time as during this age period individuals experience rapid growth. In many mild cases, the curvature of the spine isn't severe enough to warrant any direct intervention. Generally, they recommend just monitoring the spine to make sure that it doesn't get any worse. Occasionally, they'll prescribe physical therapy to focus on improving core strength, so strengthening those muscles that help hold the spine in a proper alignment, as well as focusing on posture and flexibility. There's also something called, and I'm going to butcher the name of this, the Schroth method of physical therapy, which is designed specifically for scoliosis with the goal of achieving muscular symmetry by focusing on special breathing techniques to help reshape the rib cage, which I didn't quite understand, but I thought it was very interesting. And I am sure a physical therapist would know a whole lot more about it than I do. In cases of moderate curvature, a specially fitted rigid back brace may be utilized to correct the abnormal curvature of the spine. These braces are generally worn for 1 to 3 years for proper realignment, anywhere from 12 to 23 hours a day. It is important for the individual to wear the brace as prescribed for maximum benefit. As the brace is worn during periods of growth, it is extremely important to have regular check-ins with an orthotist to ensure that the brace is adjusted properly. This will promote proper alignment as well as prevent any skin irritation. Another thing to consider is that this brace is generally worn during adolescence, which is a period not only of physical growth, but also of emotional changes, as well as the new realization of how important social standing is. Individuals may experience heightened stress and anxiety due to their appearance in a brace and will need support from their family, peers, and healthcare professionals in order to have the best outcome. And in cases of severe curvature, surgical intervention may be necessary to place rods along the spine to force something closer or approximating proper alignment. And this is generally used in cases to prevent serious complications like cardiac involvement and respiratory complications. Surgery, however, is not always possible for individuals with severe scoliosis. And with any other surgery, it's going to be up to the surgeon as well as the client's wishes as to whether it's appropriate or not. So moving on to hypermobility. It is characterized by overly flexible joints and muscles that may lead to chronic pain. This excessive range of motion in the joints is primarily caused by incorrectly formed collagen found in our ligaments and tendons. As I mentioned earlier, the tendons and ligaments help prevent injury by stabilizing our joints and limiting our range of motion. As a result, individuals with hypermobility issues may have chronic pain, fatigue, and a physical instability due to altered proprioception, which again is our body's ability to recognize where it is in space. These individuals may also suffer more frequent joint dislocations than the general population. There are multiple possible causes that can lead to hypermobility, including Down syndrome, Ehlers-Danlos syndrome, and Marfan syndrome. Although it's often benign, those with hypermobility are at risk for suffering from joint and muscle instability, fatigue, and poor posture. And it may be part of the hypermobility spectrum disorder. Sorry, I got confused there for a moment. So a defect in the collagen, which adds flexibility and strength to the connective tissue, is what causes these issues. So on to associated conditions. First, individuals diagnosed with Down syndrome are much more predisposed to hypermobility due to ligament laxity. Again, that's that loose ligaments and poor muscle tone. Because of this, many of our clients with Down syndrome experience musculoskeletal problems throughout their lives. Approximately 76% of individuals with Down syndrome acquire pes planus or flat feet at some point in their life. As you can see from this image, the ankles roll toward the midline of the body, shifting the majority of their weight off the center of the foot. This can lead to pain, altered gait, and poor balance. Over time, the altered stance caused by flat feet can lead to other conditions such as plantar fasciitis, shin splints, and more. All of those conditions are very painful, so it's important to support our clients the best we can in those situations. Hip dysplasia is also common in individuals with Down syndrome. Approximately 1 to 7 out of every 100 individuals will experience issues with hip dysplasia. And although the symptoms may vary, um, many experience limping, pain, and decreased ability to walk, as well as fatigue. And I don't know if you can really see it in the image here, the normal joint versus the hip with dysplasia. The capsule is very shallow in the individuals with the hip dysplasia, and therefore, so when the hip is moving, it can slip out of that joint very easily, and it's just not very stable. And then another condition that is very common with individuals with Down syndrome is atlantoaxial instability. So that is the joint between the atlas and, oh, I'm trying to remember the other. They're bones in the cervical spine. So they're the ones that help the head turn from side to side, up and down. So what happens is that joint is not very well supported, and that can lead to a whole host of complications, mobility issues down the line, especially if the nerve there becomes impinged. It could result in paralysis. All right, moving on. To Ehlers-Danlos syndrome, also known as EDS, there is research indicating that there is a fairly strong link between autism spectrum disorder and EDS. They have overlapping symptoms, including altered sensory perception, motor developmental delays, psychiatric disorders, nervous system disorders such as POTS, which is postural orthostatic. Oh my gosh, why did my brain just stop? It's a hypotensive issue, as well as joint pain. So EDS is a group of genetic disorders involving formation of connective tissues affecting the skin, joints, and blood vessels. And the most common characteristics shared by individuals diagnosed with EDS are hypermobility, stretchy skin, and skin that bruises easily. And so that is EDS. And then since I mentioned Marfan syndrome, I just want to briefly talk about that some. There isn't a direct relationship between autism and Marfan syndrome, but it appears that there are cases sometimes where someone with Marfan syndrome is accidentally misdiagnosed as having autism, only to be later determined to be Marfan syndrome because they do share some characteristics. The things that the characteristics shared at an early stage are speech delay, lack of social interaction, and that can sometimes lead to a misdiagnosis. And Marfan syndrome would be diagnosed with genetic testing. So that's one of the reasons why we do genetic testing when EDs are born. Or if there's a concern, you can refer to a geneticist for testing. So treatment for hypermobility really is pain management, looking at physical therapy to help support those joints, and then when necessary, use of assistive devices. Managing pain associated with hypermobility is a lifelong process because there is no cure for it. Medications that can be used are analgesics, so those are things like Tylenol. In severe cases, opioids could be used, but I don't believe that is it's not recommended as a first line of pain like treatment for hypermobility, but it's just one of the other analgesics out there. NSAIDs or non-steroidal anti-inflammatories can also be used to help decrease inflammation at joints that are irritated, to provide comfort. And then also steroidal treatments can be used in rare cases. Steroids are generally avoided unless unless it's like the only option left because they have a whole host of side effects that come along with them. So if we can manage pain with an analgesic and with an NSAID, that's the best option. And the goal of physical therapy or our exercise programs tailored to the individual's needs that strengthen muscles and provide stability to the joints, decreasing discomfort. And as for assistive devices such as braces and splints, these may be recommended by a physical therapist to help support that joint, support and protect the joint. And it's important to consult with medical professionals such as rheumatologists or geneticists for accurate diagnoses and also to access appropriate treatment options and equipment. And then moving on to sprains and strains. A sprain is a result of injury to a ligament or ligaments at the injury site, either by way of overstretching or tearing. This generally occurs as a result of twisting, falling, or direct impact to the ligament. It is commonly associated with ankles, wrists, and knees. And symptoms of a sprain include swelling, pain, bruising, and difficulty moving the joint. A strain is a result of injury to either the muscle or tendon at the injury site. This is generally caused by overstretching, overuse, and/or improper lifting technique. This injury is most commonly found in the back, neck, hamstrings, and calves. In order to prevent strains, it's really important that our clients warm up their muscles prior to any activity, utilizing proper body mechanics, making sure that you're lifting your weight over your knees or over your feet rather than over your knees, I should say. Does that make sense? And then increasing muscle and ligament strength, and then also environmental awareness, which is something that's very important, especially in our clients with Down syndrome, where they're or any other condition that would have proprioceptive difficulties, not being able to know where your body is in space accurately, or having poor muscle control can result in tripping more easily. So it's really important to make sure we're keeping an eye on our clients, making sure that, you know, the areas are free of tripping hazards, and then just helping them navigate difficult terrain as well. Treatment for sprains and strains is generally symptomatic. There are some providers who are steering away from rice as the first line of treatment, but it still seems to be the standard. And it's recommended for the first 48 to 72 hours. The first part is rest, which is advised for the first 2 to 3 days, just to keep from re-injuring the site. If someone has a sprain or strain, we want to make sure they're not putting weight on it for at least the first 48 to 72 hours. Ice is generally recommended to decrease swelling at the location of the injury. This will also help decrease pain. However, it is possible to damage the soft tissue with prolonged exposure to ice, so limiting the time on to no more than 20 minutes at a time, several times a day is best practice. I would advise using a cool pack over an ice pack, as the risk for tissue damage is quite a bit lower. And that can just be something that's put in the fridge. They do sell cool packs, and I know that they can be pricey, but if you can find something that you can keep cool in the fridge, like a cool damp washcloth inside of a Ziploc bag, will be effective as well. And you would just wrap that around the injury site. And if your client has it available, to use ibuprofen or another NSAID to decrease swelling, that's the goal of the ice, is to help decrease that swelling, which decreases pain. So if they can utilize an NSAID medication, that will also help. Next up is compression. The compression of the injury will also decrease swelling, but it's not always feasible, as you know, if we have like a strain in our back, like you're not really able to compress that very well. So in that case, we would really want to make sure you're resting areas as well as we can. But for other areas such as the ankle or wrist, you can use an ACE bandage or similar product to wrap the joint to provide some stability while it heals, and also again to help decrease swelling. And then lastly is elevation of the injury above the level of the heart to promote blood flow back to the heart and reduce swelling. And again, it's not always feasible. There are some, you know, areas that we're not able to elevate above our heart. And again, in that case, we just want to make sure we're resting that area as much as possible. Pain management is also an important part of caring for these injuries. Analgesics like Tylenol also are important, and as I mentioned, the NSAIDs as well. And in extreme cases, surgical treatment may be necessary. And this would be in situations such as a grade 3 tear, where like the muscle completely detaches from the tendon, or like the tendon completely detaches from the bone. That would require a, a surgeon to go in and reattach those tissues. Um, Aftercare for these procedures includes protecting the repair site, managing pain and swelling, and then working with physical therapy as ordered to restore function to the injury site. So next up, I want to briefly talk about osteoporosis, which we have talked about in the past. If you have not or been involved in one of our talks on osteoporosis, I believe that class is on our YouTube page. But osteoporosis is a disease that affects the strength of the bone. As you can see in this image here, there is healthy bone on the left, all the way to severely osteoporotic bone on the right, which has lots of porous areas, and as opposed to lots of little tiny ones, there's fewer porous areas, but they're larger. And what happens is it makes the bone very brittle, and increases the susceptibility to fracture. Factors to consider in regards to an individual's risk for developing osteoporosis are their age. As we age, our bodies naturally, our bones naturally start to become more osteoporotic. Hormonal changes, especially in women who are postmenopausal, can result in osteoporosis. Lifestyle is also a factor in whether a person develops osteoporosis, and that would be things about, like diet. If someone is not getting enough calcium or vitamin D in their diet, if they're consuming substances that we know will prevent our bodies from absorbing in calcium, and that's things like phosphorus. Those diet changes can affect the structure of our bones. And then there are some conditions and the medications that are taken for those conditions that can affect osteoporosis. Specifically, any condition where an anti-epileptic medication is used, epileptic medications, I'm sorry. There are many of them that have a side effect that decreases bone density. There are also other medications that decrease bone density, and I will talk about those here just a little bit. So as I mentioned before, the anti-epileptic drugs, or AEDs, do affect bone density. And those are medications like phenobarbital, phenytoin, carbamazepine, and devilprox. And we see that a lot with our clients who have a diagnosis of epilepsy. In our clients with cerebral palsy, you will also see the use of the AED medications, because many of those medications also help with spasticity, which is a common problem with individuals with spastic cerebral palsy. It is a very painful condition, so it's generally seen that the medications, although they may lead to osteoporosis, provide better benefit by decreasing that spastic muscle behavior. Also, the fact that the individuals with cerebral palsy have decreased ability to participate in weight-bearing activities. This will also decrease bone density. It has been proven that weight-bearing exercises help increase bone density by putting chronic stress on the bones. It causes the bones to remodel and build themselves stronger. Muscle weakness or hypotonicity and spasticity also affect whether that bone is going to be dense or not. And then, as I mentioned again, the medications, the AEDs, and also some GERD medications, like the PPIs, which are Prilosec, Protonix, Nexium. Those medications can also lead to osteoporosis, and they're not really sure about the mechanism of action for that. They suspect that it interferes with the body's ability to absorb calcium. But again, when that's the case, generally a doctor will make sure that in addition to prescribing these medications, they're also prescribing a calcium supplement and like a vitamin D supplement as well to promote calcium deposits into the bone. And then for individuals diagnosed with autism spectrum disorder or an intellectual disability, they actually have an increased risk for osteoporosis as well. And this is due to increased risk for alterations in diet, leading to nutritional deficiencies, an increased risk for decreased activity, and also the use of anti-epileptic medications for behavioral management is also common in these conditions. And again, those medications can lead to decreased bone density. Other medications that actually can lead to decreased bone density are diuretics like Lasix and Bumex. And I am sure you guys are familiar with at least Lasix. Um, Corticosteroids can also cause decreased bone density. You're not really going to see that with our clients who are prescribed a steroid for like a week to get rid of like a pneumonia or something like that. It would be someone who's taking steroids on a chronic basis where this would be a concern. Some antidepressants, such as SRIs like Celexa, Paxil, Zoloft, Prozac, can also decrease bone density, as well as beta blockers like metoprolol, carvedilol, and those are medications that are used to help with heart rate and blood pressure. And there are a whole lot more, but those are the more common medications that you will see in your facilities that could potentially lead to osteoporosis. So if you see those medications on your client's list, but you don't see a diagnosis for osteoporosis on their chart, or you're not seeing any supplementation, that might be something to talk to their doctor about. Be like, hey, we're kind of concerned about, their age. They're kind of getting up there. Like, can we look at osteoporosis? And really, the only way that they've diagnosed osteoporosis historically has been when there's a complication from osteoporosis. Like if someone falls and breaks a hip, they're like, oh, well, they have osteoporosis. Now we're going to put that as a diagnosis. But they can do testing such as a DEXA scan, and that will help determine whether someone has osteoporosis or not. And then this image here is an image of someone in a DEXA scan. And again, that measures bone density. So for treatment and monitoring of osteoporosis, lifestyle modification is really the standard. Focusing on low impact exercise. Um, Again, if someone has osteoporosis, their bones are more brittle, and sometimes even just moving somebody, repositioning them in bed could cause a fracture. So really making sure it's a low impact exercise. So that could be things like walking or swimming. And then diet modification and supplements, making sure, we're limiting food items that have excessive phosphorus in it. So like sodas that have phosphoric acid in it, making sure that we're not pairing that when we're taking a calcium supplement, because it will prevent our body's ability to um, put that calcium into our bones. And then also important to consider fall prevention for clients with osteoporosis. Falls that wouldn't hurt you or I could cause significant damage for our clients. So if we do have a client who falls and we know they have osteoporosis, it is a good idea to have them checked out just to make sure there are no fractures. Unfortunately, it does happen where someone has just a slip and fall out of bed and they say they're feeling fine, and then a couple weeks later they're having some pain still, and we take them to the hospital and we find out that they've got a fracture that's been worsening over time. So it's best practice just to make sure we have someone checked out after a fall if they've osteoporosis. I'd rather hear the doctor say nothing's wrong and get irritated with us than have something be wrong and we don't notice it for a while. All right, and moving on to contractures. This is the shortening of muscle and tendons, joints, as well as other soft tissues. If you consider the mechanics of muscle, in order for us to move, the muscle must be able to contract and then release. Um, they work in an antagonistic pattern. So there's one muscle that's going to contract and another one that's going to release. You can think about this in your upper arm. When the bicep contracts, the tricep releases, and when the tricep contracts, the bicep releases. So it's that push-pull between the muscles that allows us to move. When a contracture occurs, the muscle is shortened, and typically chronically, and it's very difficult to get the other muscle to contract and allow that initial muscle to relax so that the limb ends up in one position and becomes very difficult to move. Um, Without treatment, this condition can become permanent and the level of severity can increase over time. As a result, this can lead to chronic pain and must be considered when caring for our clients with contractures, especially for our clients who are unable to communicate verbally with staff that they are experiencing discomfort. Another consideration for our clients with contractures is the potential for skin breakdown. Due to the chronic flexion of muscle and resulting loss of movement, clients might not be able to reposition their bodies with the same frequency as the general population, and in severe cases, they are unable to reposition at all. For this reason, it becomes incredibly important to reposition clients at least every 2 hours to prevent pressure injuries. It's important to consider that in our adult residential facilities and in our residential care facilities for the elderly, pressure injuries are restricted healthcare conditions, requiring a restricted healthcare plan for stage 1 and stage 2 pressure injuries. That means if a client develops a stage 1 or stage 2 pressure injury, their home is required to develop a plan of care under the guidance of a physician, and a licensed professional must personally educate all members of staff on how to properly care for the pressure injury. In severe cases, such as a stage 2 or stage 3 or 4 pressure injury, the client will not be able to remain in the home until the wound is completely healed. For some of our clients, a stage 3 or 4 will never heal and they never get to go back home. So it's really important to make sure we try to prevent these injuries at all costs. Another aspect to consider when it comes to potential for skin breakdown is that due to chronic flexion of muscles, some limbs or digits may come into constant contact with other parts of the body. As you can see in this image here, the individual's fingers are curled into the hand. This can result in a pressure injury as well. So it's important to work with physical therapy if possible to facilitate as much movement as possible to prevent further injury. There are cases where the muscles are too rigid to allow for movement, and in that case, you will want to make sure there is some type of barrier between the skin, such as a washcloth, as you can see in this image. Another consideration specific to the hands is the growth of fingernails and the potential for the nail to grow into or embed itself into the tissue. Proper nail care is essential to prevent this type of injury, but it does need to be performed by someone who is qualified to do that nail care. Um, so there's that. And next to the associated conditions for contractures. Um, Contractures can result from things like traumatic injuries or burns, and this is due to scarring from the damage to the soft tissue, resulting in shortening of the muscles, tendons, and or ligaments. Arthritis is a condition that I will discuss in just a little bit, but it can also lead to significant joint pain, resulting in loss of mobility. Prolonged immobility can result in contractures as muscles stiffen due to lack of blood flow and impaired nerve signaling. And then genetic conditions such as muscular dystrophy and Dupuytren's contracture, which is a contracture of the hand, um, can also cause these contractures. Um, and as many of you are probably familiar with contractures, as they're very common in our clients with diagnosis of cerebral palsy. In individuals with CP, especially spastic CP, one or more muscles are shortened due to increased muscle tone that is stiff and resistant to stretching. Additionally, the damage sustained in the brain during the perinatal period can disrupt normal muscle development, reducing muscle volume, resulting in physical muscle shortening. Studies have also shown that individuals with cerebral palsy have increased collagen, connective, and fatty tissues in the muscle, resulting in increased muscle stiffness and the inability for the muscle to grow properly, resulting in a predisposition for contractures. So contracture treatment varies depending upon the severity of the contracture. As I mentioned previously, it's very common for individuals with contractures to experience chronic pain. In these instances, it's important to recognize when their pain is not being well controlled, either by their ability to communicate with you directly that they are uncomfortable, or through recognizing facial cues, body positioning that's signaling that they are in discomfort. Um, when this when a client who is demonstrating facial grimacing, or they're having behavioral action, or they're behaviorally acting out, which is common for them when they're uncomfortable. It's important to recognize those instances and then treat appropriately. Check your MAR, make sure you have a PRN. If a PRN isn't effective, try another. If you don't have another one, talk to the doctor about getting like backup pain management. If the the pain that the client is experiencing is severe and what you have on hand is not going to cover it, and the pain is just not tolerable for them, please take them to either urgent care or the ER to have their pain level addressed. Um, Especially if this is a new onset thing, this could be a sign that something else is going on as well. Um, and then when it comes to our PRN medications, make sure you're documenting why they're being given. If it's an individual who can't communicate verbally, you would just put like pain and then put facial grimacing, or they're hitting their hand against the side rail of the bed, which is what they normally do when they're in pain. And then making sure that you document your follow-up, which is, generally within 30 minutes to an hour, and you can say, they're smiling now, pain is resolved, or, if the pain isn't resolved, document that it's not and that you're going to try something else. And then, sorry, I got lost here for a second. And then other medication therapies that you may encounter are antispasmodics and muscle relaxers, such as baclofen and clonazepam. Clonazepam is generally prescribed for anxiety, but it also reduces that increased muscle tone as a result of muscle spasticity. So it can be very helpful in individuals with cerebral palsy. In conjunction with other therapies, heat therapy can be used to help relax tightened muscles and provide some relief from discomfort. And heat therapy applied prior to physical therapy um, is really effective in helping physical therapy become more effective. Physical therapy for the treatment of contractures focuses on manual stretching to passively reduce muscle stiffness and improve range of motion. This is not always possible, as some individuals become too contracted to allow for like any extensive range of motion. Additionally, for some clients, physical therapy can be traumatic, and either they refuse, or in some cases, if they're conserved, the conservator refuses physical therapy treatment, which is completely their right. We just want to make sure that we do continue to monitor for complications related to worsening contractures. Physical therapists can also recommend custom orthotics or splinting to either prevent further loss of range of motion and worsening contractures. If adjusted correctly, they can provide prolonged passive stretching of that affected joint. And that shouldn't be uncomfortable, but just it'll gradually stretch that joint out. And as that splint is progressively um, fitted, it should help further increase that range of motion. And like I said, this is a very light stretch. It should not be uncomfortable for the client. A physical therapist can also help clients engage in active and passive range of motion, as well as strengthening exercise designed to increase joint flexibility, improve strength, as well as increase muscle to help stabilize that joint. Injections can also be utilized to benefit the client suffering from contractures. Botox and collagenase are the most commonly used injections for the treatment of contractures. Botox, which is a paralytic, can help relax the muscle and reduce spasticity. This treatment generally lasts about 3 to 4 months. Collagenase is an enzyme that, when injected under the skin, breaks down excessive amounts of collagen at that injection site, um, which will help lessen the severity of the contracture. And this treatment is more common in the Dupuytren's contracture, which is that contracture of the hand. And I know I'm butchering the name of that. I apologize. Other injections that are sometimes used are corticosteroids that reduce inflammation in the joint and improve mobility. But it is important to know that it's a temporary fix and can lead to atrophy of the joint, which is breakdown of that tissue. And could potentially require more intervention in the future. So it's really just like a patch fix until we can come up with a better treatment plan. And then phenol or other alcohol injections disrupt the nerve function at the injection site, basically providing a nerve block, um, which ultimately reduces muscle tone and spasticity, um, reducing the pain from that contracture. This relief generally lasts about a few months, but that nerve will eventually regenerate. And this treatment is generally only pursued when Botox injections and medications like oral or medications are not enough for relief. And in severe cases, surgery may be needed. Surgical release is reserved, of course, for severe cases of contracture. The goal is to restore lost range of motion through several different methods, either by cutting into the tendon to give it more length, by replacing the tendon with a tendon from another part in the body, or cutting the fascia around the muscle. And there's actually a whole bunch of other surgeries, but those are the more common ones. In some cases, a surgeon may recommend an arthroplasty, which is a procedure in which a joint is restored to its previous function with replacement, or sometimes a total joint repair is done. And moving on to the last bit here, I wanted to talk about arthritis. There are 3 types of arthritis, osteoarthritis, rheumatoid, and then gout. So arthritis is and there are 3 that I'm going to talk to. There are a whole lot of arthritis. There's over 100 different arthritic conditions. Um, and these conditions are characterized by inflammation, pain, stiffness, and limited range of motion. Osteoarthritis is the most common form of arthritis, and it's caused by general wear and tear of the cartilage in the joints, resulting in pain and impaired mobility. Individuals with osteoarthritis will have pain that increases with activity or worsens throughout the day. Rheumatoid arthritis, however, is an autoimmune condition, meaning the immune system attacks the lining of the joints. The pain is worse with extended periods of rest, and the joints may appear red, swollen, and warm to the touch. There may even be nodules under the skin near the joints as well. The cause of rheumatoid arthritis isn't well known, but it's thought to be a combination of genetics and environmental factors. It is a progressive disease, and if not treated appropriately, can result in permanent joint damage, loss of function, and disability. Gout is an inflammatory joint condition in which uric acid levels in the body are elevated, leading to crystal development in the joint. It's incredibly painful, and it is the result of diets high in purines found in red meat, organ meat, seafood, alcohol. Some medications, such as diuretics and low-dose aspirin, can increase uric acid levels. Other possible causes could be rapid breakdown of cells from chemo, enzyme dysfunction that leads to overproduction of the acid. It could be from kidney failure, genetics can play a part. It tends to be more common in men than in women, and treatment of this condition involves pain management, anti-inflammatories, lifestyle modifications, so changing diet and weight, as well as medications such as allopurinol, which reduces the production of uric acid. And it's important to note that medication will not stop a gout attack. It will help prevent a gout attack from occurring, but it will not stop one that is in process. As with the other conditions, individuals with cognitive disabilities are 3 times more likely to have arthritis compared to the general population. Our individuals on the autism spectrum have that increased risk of hypermobility, which of course increases the risk for arthritic conditions due to that joint instability. And our individuals with cerebral palsy, due to that loss of muscle tone, movement, and coordination, it can lead to extra stress on the joints, resulting in the development of osteoarthritis over time. And sorry, I know we're running out of time here. I will try to blast through this treatment page real quick. Medication is really important at managing arthritic conditions. Our clients experience joint pain, are not able to engage in like their normal activity levels. So if we can provide analgesia, and NSAIDs, corticosteroids, anything that we've got in our bag of tricks to help relieve that pain, so that way they can participate in their normal daily activities, what help keep the health of that joint for as long as possible. For anyone who For our clients who have opioid analgesia for pain management, please make sure that the medication is locked away in their NARC box. Make sure your staff are properly trained in administration and documentation of this medication. And also, please ensure that Narcan or naloxone is available for the use in the event that a client overdoses from the medication, becomes unresponsive, and needs resuscitation. It's also important to make sure staff are aware of the signs of opioid overdose and how to administer the medication. And there are like little quick infographics that you could probably find online, print out, and keep in your med cart area. Also for treatment is disease modification, and it's necessary in cases such as rheumatoid arthritis, as it's a progressive disease and needs to be treated as such. One medication type that you might encounter are DMARDs, which are disease-modifying anti-rheumatic drugs such as methotrexate. They slow the progression of rheumatoid arthritis. As well as biologic response modifiers. Those are a new treatment and they target specific parts of the immune system to slow the progression of the disease. And like I said, RA is a progressive disorder. So if it is left untreated, it will continue to get worse to the point that it can cause disability. Physical therapy is used to increase joint flexibility, strength, and range of motion. Lifestyle changes, including diet modification, weight loss, regular low impact exercise, hot and cold therapy, assistive devices, walkers, canes, can be used to lessen symptoms of arthritis. And physical therapists can be utilized to assess for appropriate assistive devices. And in extreme cases, surgery may be necessary to either repair the joint or replace the joint. You're most likely going to see that in a hip, knee, or shoulder, but any other joint like the wrist, ankle are also fair game for that. And I'm sorry we're cutting that real close, but if you want to ask any questions, please feel free to unmute or you can ask in the chat box. And before I lose any of you, if you haven't already put your first and last name in the chat box with your organization so we can send your CEU, please do that before you leave. All right, it looks like we probably don't have any questions, which is totally fine. If you do think of